So what we're looking for is keratoconus. And what we're looking for is keratoconus that's not obvious, because you don't need any other measurement if one measurement is obvious. You have a surface corneal topography that is completely classically distorted. That's all you need. You don't need any other machine. But so the bane of the existence of refractive surgery is looking for that needle in the haystack. It's looking for the case where tomography looks normal, and you're just like, well, what do you think? So in our clinic, I guess here we are, 2024. Here's the multimodal approach, okay? Now we're getting into the machine testing, and obviously topography, the surface of the cornea, tomography now, which of course is the gold standard, using back surface information, which we get obviously from the pentacam. Now, I'm getting here to what I think is probably the most sensitive parameter, if you're going to take one parameter and compare them all, is epithelial mapping. It means that focal thinning of the epithelium in the wrong place turns out to be the most sensitive way of picking up keratoconus when topography, tomography, and all these other parameters are normal. Now, for us, in the last few years, having adopted the Corvis technology, this has added a whole other axis of impression creation for us, because we will be influenced by observing a difference in the corneal biomechanical index, the CBI, and then even more so, of course, the total biomechanical index, the TBI. I was one of the many contributors to the Renato Ambrosio paper, which I think was a landmark paper, because he really managed to gather enough data from around the world on a very rare condition called ectasia, and with pre-op data. And he was able to really give us a fairly convincing argument that the TBI is a useful parameter for making an impression as to whether this eye has a susceptibility that is low or high for developing ectasia. About the Corvis, I would say, because I wasn't using it, from the beginning. I'm a late comer to using it myself. We've had it for 3 years. We have 4 devices in our clinic because we do testing on everyone before and after surgery. And what I've always felt that corneal biomechanical data is a useful tool for developing an impression of the susceptibility of a cornea to ectasia. But the Corvis is now a much more sophisticated way of deriving the mechanics of the cornea. If you have an example of an eye where the clinician is unsure about the presence of keratoconus pre-op, in a pre-op exam, if you have mechanical information of the cornea, which we're obviously getting from the Corvis, then that measurement does give you an added comfort or not that this cornea is adequate for refractive surgery. And ectasia is rare. It's not common. It's 1 in 1,000 to 1 in 10,000, depending on who you look at and how much multimodality is being used. Those using more multimodality have less ectasia. That's for sure. But I think that adding mechanics to your approach in evaluating refractive surgery patients is, I would say, has to be a gold standard now. It's not a research tool. It's something that everybody doing refractive surgery should also have that measurement incorporated into their decision tree as to whether they can operate on a cornea or not. The reason it's important to employ a multimodal approach is that we don't have a litmus, white, black, yes, no way of detecting keratoconus. And, as we know that eye rubbing is one of the major factors also in people developing both keratoconus and post refractive surgery ectasia. We need to have I think it's very important for us to have an understanding of the mechanical strength of the cornea, because that's what we're talking about. The Corvis is a totally different ballgame. Because it's actually a multifactorial measure of mechanics. It's looking at the shape change over time with force applied, and it's a far more sophisticated way of getting an impression of corneal mechanics. And the reason why it's critical to use a multimodal approach, not just one thing, like not just the mechanics, is because ectasia is actually a very difficult thing to detect pre-op, keratoconus. And so, this multimodal approach of multiple devices, including history and ethnicity and all that gives us a better opportunity of getting it right. But the TBI is an example of how, the overall specificity and sensitivity of your impression can be improved, by comparing the information from your shape devices, your epithelial maps, your anterior surface, your posterior surface, with an actual measured mechanical strength or mechanical behavior of a cornea. And so that we've opened another axis using the CBI and the TBI. This is in my practice, and everyone knows that I lean a lot on epithelial thickness mapping. It's an extremely sensitive way of picking up keratoconus when other parameters are, when the tomography are normal. Even the mechanics can be normal, but then the epithelial map can be, the canary in the mine, right? I think difference maps are very important, but again, it's the multimodal approach. It's using a history, ethnicity, all of those things, eye rubbing, topography, tomography, epithelial maps, and a mechanical information from the cornea. And all of those things together is the way that we reach our, let's call it, final decision. Because we have, doing the surgery is a binary decision. You either do it or you don't. So you need to have a certain amount of confidence to offer surgery to a patient. And it has to be done, I think, with all of these parameters together. The mechanical component, which of course has come in much more scientifically with the Corvis, is a shining star in our multimodal approach. So I would say that there are cases that we come across where we're all ready to go, and we've decided that the epithelial map, the tomography, the topography is normal, and there's enough cornea to take out that amount of tissue. And then we see a very high corneal biomechanical index of, very, very basically, a softer cornea. And then we see that the TBI is actually quite high. And this throws a little bit of sand in the engine, because it makes us feel that, well, maybe we shouldn't be so confident on this cornea. There's this sort of case where we might say, hey, you know what, you're only 21. Let's see you in a year's time, and let's retest everything and make sure that everything is, good to go. Because the refractive surgery is not an appendicectomy. You don't have to have it when you need it. You need it when you're wearing glasses, but you don't have to have it at that point, because glasses and contact lenses work. So I think that, there are cases where the biomechanical measurement puts a little stopper on things where we would have gone ahead, and that's different from before because we didn't have the measurement before. Likewise, there are cases the other way around where we're a little bit concerned about the morphology of the cornea, the epithelial map, the topography, the posterior surface, but then we look at the biomechanical indexes and we're like, well, actually, this is a very stiff cornea, and the TBI is like nothing. So that actually factors into our confidence, let's say, in saying, well, yeah, okay, these parameters are not totally normal morphologically, but the mechanics are now biasing us towards thinking, well, I think it's a normal cornea. And of course, you have the choice of PRK, which is less biomechanically aggressive to the cornea than, LASIK or SMILE.